Anyway, big moment. Keynote speaker. Very excited to introduce to the stage Professor Simon Lloyd from Manchester University.
Thank you very much, Alex. I'm not sure I've ever been bigged up quite so much in my life. I appreciate it. It's an honour to be here for the first BSHAA Roadshow, and particularly because it's World Hearing Day tomorrow. So what I thought I would talk about, I don't know whether, oh, they're there, are they? Is, where's the next one? Yeah. Is when you should refer to ENT and what happens to the patients after they've been referred to ENT, because that relationship between your practices and our practices is absolutely critical for optimizing the care of our patients. So I'm going to cover a few different things. I'm going to firstly talk about sudden sensory neural hearing loss. And this is a subject that's really close to my heart. I've written to journals in general practice on a number of occasions about this to try and encourage GPs to refer urgently. So I'll talk about the current protocols for that and hopefully make that clear as to what can be referred and what we can do about it. And then I'm going to talk about what to do about single-sided or asymmetrical sensory neural hearing losses. So when we carry out MRI scans, what kinds of pathology we might see. I'm going to talk a little bit about conductive hearing losses because as an otologist, there's lots of things that I can do to fix patients' hearing if they've got a conductive hearing loss. So it's particularly important to refer those patients to an ENT surgeon. And talk a little bit about the discharging ear. I'm not going to focus on that because that's a huge topic that's not so relevant to you guys. And then finally, I'm going to talk about profound hearing loss, and I'm going to get on my high horse about the criteria for cochlear implantation and how everybody should be aware of what that is so that we can try and get that pool of unmet need met and get the patients that are out in the community with profound deafness there to get their hearing back. So this is the British Society of Otology protocol for managing patients with sudden sensory neural hearing loss. And you probably can't see it, so I've zoomed in a bit on the critical parts. So the bit on the bottom left is the criteria for what sudden sensory neural hearing loss is and how they should be referred and when they should be referred. So if they have had 3 consecutive frequencies with a 30 dB or more loss, then that's how we define the sudden sensory neural hearing loss. I appreciate that there will be people that fall outside that criteria, but broadly speaking, that's how we define it. And if they've had that hearing loss within 4 weeks, then we would like those patients to be referred to us, and they need to be referred urgently. So if you see somebody in your practice that's in that situation, get them to go and see their GP in the next 2 or 3 days and get that GP to refer to the on-call ENT surgeon, because the treatment for sudden sensory neural hearing loss is to give steroids either orally or intratympanically, and if you give them early, the evidence suggests that the effectiveness is greater, so it's really important to make that early referral. So if we have picked up somebody with that sort of hearing loss, we then also arrange for them to have an MRI scan of their inner ear, just to rule out other pathologies, particularly vestibular schwannomas, and I'll touch on that in a minute. And then that's the protocol for the patients that come to us. So initially, the guidance says that patients should have oral steroids, so we give oral steroids up to 60 or 80 milligrams daily for 5 days, and we then retest them, and if their retest shows there's no improvement, we'll go on to carry out what's called intratympanic injections of steroids. So we inject them under local anesthetic through the eardrum. They get absorbed into the inner ear, and the evidence would suggest that the amount of steroid that gets into the ear that way is about 200 times higher than it is when you give it orally. Although actually in reality, when you compare oral versus intratympanic steroids, it probably doesn't make an enormous difference. But there is a big study called the Starfish trial that we're currently involved with to try and decide whether or not oral or intratympanic or a bit of both is the most effective way to treat these patients. So I'm going to move on now to what to do about unilateral sensory neural hearing loss, or asymmetrical sensory neural hearing loss. So just make sure I'm still on the right slide. Yep. So you can see on the left-hand side a typical audiogram with a bilateral high-frequency sensory neural hearing loss, but the left one is much worse than on the right. And that's the sort of hearing loss that needs to be referred. It doesn't need to be referred urgently. It can be referred routinely, but again, they could go back to their GP, get a referral to ENT, and in that situation, we would carry out a routine MRI scan, and that's what you can see on the right-hand side. I'm not sure if I can... Is that the only screen, that one? So this is the vestibular schwannoma here that was picked up on this patient. So this is an axial scan through the head, so a horizontal slice, and they've had a contrast injection, so the tumor lights up brightly. So that scan allows us to make sure that we understand what pathologies there are. 95% of the time, these scans are completely normal, and we don't need to do anything at all except reassure the patient and make sure their hearing aids are optimized. But if we do pick up a vestibular schwannoma or another pathology in that area, then obviously they need to be referred on. And there are some fairly strict guidelines published by NICE about who should get an MRI scan. So, and there's a lot of controversy around this, but the guidance that NICE have accepted is 15 dB hearing loss in 2 adjacent frequencies between 0.5 and 0.8, and 8 kilohertz rather. So if you see somebody with that criteria, it doesn't have to be quite as severe a difference as the one that you saw in that slide. Get them to go and see their GP. Okay, so I'm going to move on to conductive hearing losses here, and you can see a range of pathologies there. So on the left-hand side, you've got otitis media with effusion, which is a very straightforward, simple thing to correct. Sometimes it gets better by itself. Sometimes you can treat them with hearing aids, but most patients that I talk to about hearing aids for this don't want them. They want to have a myringotomy, incision in their eardrum, and drainage of the fluid. So I'm not going to go into any more detail on that subject because it's quite straightforward. But I would like to talk a little bit more about the other 3 subjects there. So tympanic membrane perforations, retractions, and acicular erosion, and what to do if you've got somebody with a conductive hearing loss and a normal-looking eardrum. So this is a pretty extreme version of a perforation. There's hardly any eardrum left, and you can see the acicular chain. This is the perforation here. That's the malleus, which is shortened, and then this is the incus, and that's the stapes, and this is the round window niche here. So that's a big perforation, and when somebody's got something like that, they don't necessarily have to have anything done if it's not causing too much trouble, but something like that would be causing quite a considerable conductive hearing loss, and they would be at risk of getting infections, so we would usually recommend that we repair something like that. So you can see on the right-hand side one of the techniques that we can use to repair it. What we do is we lift up the eardrum, we slide a graft underneath the eardrum, which can be cartilage or some of the lining of the muscle above the ear, and that then acts as a scaffolding for the eardrum to regrow. And that's really successful. It's about 90 to 95% successful, depending on who's doing the surgery. just being honest. So what do you do if you've got somebody with a conductive hearing loss and a normal eardrum? Well, this is not an uncommon situation, and by far the most common reason for this type of circumstance is otosclerosis, where the innermost hearing bone gets fixed. And for these patients, there's several different options. You can just wait and see what happens. If they don't want to have any intervention, that's fine. They can have a hearing aid. Some patients, if they have trouble with their hearing aids, can have a bone conduction hearing implant, which I'll talk about in a little bit. Or they can have a stapedectomy, which is where we basically remove the arch of the stapes. We make a tiny hole in the footplate of the stapes and pass a piston, which is only 0.6 of a millimeter wide, through the hole, and then hook it around the middle hearing bone, the incus, and that way the sound waves can get through the acicular chain into the inner ear, and that bypasses the fixed stapes, and that's a really successful operation. 90% of patients get normal hearing after that sort of surgery. And then a quick word on ossicular erosion. So this isn't a perforation. What you can see here is a retraction of the eardrum. So this is a right ear. So this is the back of the eardrum. You can see the round window there. This is the stapes, and this is the incus. And there's a gap between the two. So over time, they've had multiple infections, and that incus has got damaged, and there's no longer a connection, and that causes a conductive hearing loss. And we can repair that, usually with very good outcomes. So there's different ways to do it, and it very much depends on whether or not the stapes is damaged or not. But if the stapes isn't damaged, we can use what's called a partial ossicular replacement prosthesis. And if the stapes is damaged, if there's no arch on the stapes, then you can use a total ossicular replacement prosthesis. And that basically just bridges the gap between the footplate of the stapes and the eardrum, so that the sound waves can then get through to the inner ear. And this is an example of a surgical case which basically shows a titanium ossicular prosthesis. That's 2.5 millimeters in length, so it's all pretty small. So what about recurrent discharge? Well, again, if you've got somebody in your clinic with a discharging ear, then they really need to be referred firstly to their GP and then potentially on to us as ENT surgeons. The common reasons why people's ears discharge are otitis externa, and you can differentiate that from otitis media because it's really, really painful. So if they've got discharge and pain, it's almost always otitis externa. But if they've got discharge and it's not painful, then they've probably got a perforation or they've got a cholesteatoma. And although otitis externa and infected perforations are fairly urgent, cholesteatomas can be referred relatively routinely. So I'm going to move on now to other hearing rehabilitation options for patients with different types of hearing loss. And one of the most common implants that we use in our practice is one of a number of different bone conduction hearing implants, and historically by far the most common has been the bone-anchored hearing aid. So I'll show you those and then show you some of the new generation of devices that we're implanting now. But mostly these devices are used for patients that have a conductive hearing loss and don't get on with their hearing aids, so they get discharge or pain or any other issues you might find. There are several problems with these sorts of issues. And the other condition that we can treat with bone-anchored hearing aids or bone conduction hearing implants is single-sided deafness. So they're basically like a cross aid where the signal is taken from the deaf side to the good ear in the same way as you would for a cross aid or a bi-cross aid. So these are the two main bone-anchored hearing aids. I shouldn't really call them that because the Oticon device is on here and it's not a bone-anchored hearing aid. But they're two transcutaneous implantable devices. So the one on the left is the cochlear device, which is the true bone-anchored hearing aid. And the one on the right is the Oticon Ponto device. They both work in exactly the same way. The Ponto has the benefit that you can fit a cochlear processor onto it, as well as the Oticon, but although the other way around isn't the case. And they work in a very similar way. So we basically make a tiny nick in the skin, drill a tiny hole in the skull, and we put a titanium screw through that hole and screw it into the hole in the skull, and that then heals, and the titanium integrates into the bone of the skull, and the processor can then be clipped onto the bone-anchored hearing aid. And this is actually two fairly old pictures now, but on the left-hand side you can see the abutment very clearly. I only include this one because they've had all of the hair follicles removed and you can see the abutment really clearly. We don't actually do that anymore, so they're cosmetically much more discreet than they were. And then that's the old-fashioned bone-anchored hearing aid processor. And you can see here the three almost current, these are the BSHAA 5 processors, there's a BSHAA 6 now, but there's the three different strengths of processor, depending on how bad the inner ear function is. So if you've got a threshold, bone conduction threshold of 45 dB, you go for the least strong of those processors, and if you've got a bone conduction threshold of 65 dB, you have to go for the superpower one, which really drives that abutment and gets the sound into the bone much more strongly than the more basic processors. And I've never been a fan of the bone-anchored hearing aid because of the transcutaneous screw. I mean, if it was me, I'd be horrified to have this thing sticking out my head. But it's revolutionized the hearing of a lot of patients, and now we've got a new generation of device that we can use. So these are all percutaneous bone conduction hearing implants. So we've got the bone bridge on the left and the ossea on the right. So the bone bridge is a Medel device, and the ossea is a cochlear device, and they both work in the same way. They both have two components. There's a part that's implanted underneath the skin, and there's an external processor which you can take on and off, and that attaches to the bit that's under the skin by magnetism. So essentially what you do with the surgery for the bone bridge is you make a little well in the bone behind the ear under anaesthetic. It can be under local anaesthetic or general anaesthetic. And you slide the implant coil underneath the skin, and then there's a small device within the implant that has a piezoelectric crystal within it, and that's implanted within the well that you've made, and then you screw the device into the skull. So the piezoelectric crystal, when it vibrates, sends the vibrations through the screw into the skull and then bypasses the conductive mechanism so that the patient's hearing is restored. And the ossea works in a very similar way. They use the cochlear screw that we use for the bone-anchored hearing aid, and they screw the ossea device into that screw. And again, the sound waves go through the skull via a piezoelectric crystal that vibrates. And this is the criteria for the bone bridge and the ossea. So you have to have a bone conduction threshold of 45 dB or better for the bone bridge, and cochlear say it can go down to 55 dB for the ossea, so maybe they get a little bit more gain with their device compared to the bone bridge. And then there's the Medel adhere. I'm not going to dwell too much on this. We've tried to use it. We don't really find it that helpful. It's similar in design to the BSHAA in that you've got a vibrating external processor, but rather than having a screw transcutaneously, you stick it to the skin, and that's where the problem lies. The signal just doesn't get through the skin effectively into the inner ear, so it just doesn't give the patients the gain that they're looking for when they're using it. So that's the treatments for conductive hearing loss if you can't use a normal hearing aid. But what do we do if you've got a sensory neural hearing loss? Well, you'll all be very familiar with hearing aids, but not everybody can use a hearing aid. So there are some other options. So there's middle ear implants, and then for those patients that have a profound deafness, there is also the option of a cochlear implant. And then I've put at the bottom there something called an auditory brainstem implant. That's something that we offer in our department in Manchester. There's only 2 centres in the UK that do it, and that's used for patients that have got profound bilateral hearing loss and can't use a cochlear implant because there's no connection between the cochlea and the brain, and that's usually because either they've been born without a cochlear nerve or the cochlear nerve has been damaged through surgery, for example, if you've taken out vestibular schwannomas or something like that. So this is a picture of the sound bridge, and you can see again, it looks very similar to the ossea. It's got a coil, it's got an electronics package. Those components are implanted underneath the skin, and then there's an electrode that comes off this device. You can see that there, and there's a little piezoelectric crystal inside that part at the end. That's called the FMT, and that FMT can be attached to a number of different designs of clip, and that clip can be attached to the ossicular chain, or if there's no ossicular chain, it can be placed on the round window membrane so that the sound can be transferred directly into the inner ear. And those have the ability to drive the ossicular chain. So if patients aren't getting what they need from their hearing aid, you can actively drive sound into the inner ear using the sound bridge. And this just shows you roughly where it's placed. So again, the processor is placed underneath the skin, just behind the ear. There's an external component that you can take on and off. It looks exactly the same as the bone bridge processor. And the criteria for the sound bridge are slightly different to the other bone conduction hearing implants. They can go to a much greater bone conduction threshold, so you can get amplification down to about 65 decibels with these devices. So we've got coverage of everything down to 65 dB now with all these devices if they can't use a hearing aid. Where we struggle a bit is from 65 to 80 dB because we haven't at the moment got a device where we can get amplification to that level. Unfortunately, there was a device called the Carina. I don't know if anybody's familiar with that, but it was taken off the market a year or so ago because it was really technically quite challenging implanting it, and they had several complications. So that device was the great hope to fill that gap between 65 and 80 dB, but it unfortunately hasn't quite worked out that way. So the sound bridge can improve the gain of hearing from anything from about 13 dB up to about 30 dB, which is a really good gain. If you compare that to a normal hearing aid, it's around 7 to 27 dB, so slightly better than a normal hearing aid. And you can also use them for mixed hearing losses. So if they've got a sensory neural loss and a conductive loss, you can get a good gain from that as well. So I'm going to move on now to cochlear implantation. So we do a lot of cochlear implants here in Manchester. It was a pleasure to see Rian today. She's on the BCIG stand, but she's our adult cochlear implant coordinator. We've got the largest CI service in the UK here in Manchester. And it's really been one of the greatest revolutions in healthcare, I think, in the last 50 years. It's allowed profound patients to regain hearing where they've not been able to hear before. And you'll probably be fairly familiar with how they work. They have two components, similar theme to the other devices that I've spoken about. And they have an electronics package that is placed under the skin, just behind the ear. And again, there's an electrode, but rather than the electrode being attached to the ossicular chain, the electrode goes into the cochlea, and that array has a number of electrodes along the length. The number of electrodes depends on which company. It doesn't really matter how many electrodes there are. They all work in a very similar way. And then there's an external component of the processor which picks up the sound, converts it to an electrical signal, sends a radio signal to the coil underneath the skin, and that radio signal is split up into frequency-specific bands and sent to the various electrodes within the cochlea. And that then electrically stimulates the cochlea, where previously they wouldn't have been able to get any audition because their hair cells are damaged and they're just not able to pick up the sounds effectively. And we were fortunate enough to get a change in the criteria for cochlear implantation in the last few years. So this slide shows you what the old criteria were and what the current criteria are. So you can see this green box here is the group of patients that would have met criteria previously. Sorry, this red box rather. So you had to have thresholds at 90 dB or greater at 2 and 4 kilohertz. So pretty restrictive criteria. But when NICE reviewed this and introduced the new criteria are set at 80 dB, and you can have a hearing loss at 2 frequencies at any of the frequencies between 500 hertz and 4 kilohertz. And you also have to have a certain degree of speech discrimination loss, so you have to have a speech discrimination score of 50% or worse. But if you've got that combination, then you meet the criteria for cochlear implantation in adults. In children, it's slightly different because we can't do speech testing in them. So we use the pure tone audiogram, and we then look at whether or not they're progressing with their hearing aids. And if they're not progressing and they meet that criteria, then we can go on and implant the children. And the adults and the children are two very different groups. So the children are usually congenitally deafened, and we have a very finite window of time where we can implant the cochlear implant. So we have to do it before the age of 4, because otherwise the brain loses their ability to process sounds. So if we implant somebody that's deafened at birth at the age of 6, they won't get any benefit from the cochlear implant. And that's why the neonatal hearing screening program has been absolutely critical for the quality of life of all of these children that have been profoundly deafened at birth. In adults, it's more difficult, and I'm going to talk about that in a little while. So these are the sorts of audiograms that you might see for somebody that would be a candidate for cochlear implantation. I've put these up on purpose because a lot of people that do hearing tests in the community may not be aware that these types of hearing loss are within criteria for cochlear implantation. So, you know, this patient on the right has normal hearing thresholds in the low frequencies, but has this ski slope loss, and by the time they get to 2 kilohertz, the hearing is in the profound range. And similarly here, this looks like it could be aidable hearing, but by the time you get down to sort of 2 kilohertz, again, it's around 100 dB. And those audiograms are both within criteria for cochlear implantation. And I'd really encourage all of you to just go to the BCIG stand and grab one of these, because it's the criteria that we use. And if you have this up in your consulting rooms, it will just be a reminder about the criteria so that you can make sure patients that are profoundly deaf and aren't really getting that benefit from the hearing aid that they're looking for, to refer them. They can, again, be through their GP into the local cochlear implant centre, and there's 22 centres across the UK, so they should be readily accessible for patients across the country. So these are the 3 devices that are currently on the market in the UK: Cochlear, MED-EL, and Advanced Bionics. They all work in exactly the same way. They all have subtle differences. The hearing outcomes are the same for each one, but the facilities that are available through the processors vary from one device to another. The design of the electrodes is slightly different from one design to the other, but fundamentally they're all exactly the same. And these are the external processors. So actually these are all the on-the-ear processors. The MED-EL and Cochlear devices also have an off-the-ear processor, which some patients like. It's probably a little bit more discreet than the on-the-ear processors. And these are the various different designs. We could probably talk for hours on designs of electrode for cochlear implants, but MED-EL pride themselves on the fact that they have a range of lengths. So they have software where we can measure the cochlear duct, and we can then choose the length of device that we use, so that we cover the entire cochlea. It's slightly debatable whether that makes a big difference. There are also electrodes where that are very fine and delicate, and we use for patients that have still got residual hearing. So we can preserve that hearing in 70% of cases, and that allows them to not only use their natural hearing, but use the cochlear implant in the high frequencies to augment their natural hearing. So how do we do cochlear implantation? Well, this is just 2 or 3 photographs of what we do. They're not too gruesome, I hope. So we make a little cut behind the ear. We drill away the bone from behind the ear, and that allows us to get access to the middle ear. And then we place the implant underneath the skin, again, just behind and above the ear. And we then go on. Could we just start that video? I don't know whether we can. Yeah, that's brilliant. We go on to pass the cochlear implant into the round window and then slide it into the cochlea, so it coils around the snail shell of the cochlea. So this is just drilling away the bone to expose the round window. The round window is just here. And then you make a little nick in the round window membrane. Get a little bit of a leak of the fluid from the inner ear when you do that. And then you just pass the electrode through that hole. This is a floppy MED-EL electrode. Try not to shake too much. And then you just very slowly and gently insert that into the cochlea. And they have been amazing. For children, it's allowed them to go to normal schools, develop normal speech, have normal lives. For adults, it allows postlingually deafened patients who were active parts of the community to go back to work, to be able to communicate with their families. And these are the sorts of outcomes we can expect from adults. So if you do BKB testing or AB word scores, you score in the range of about 80 to 90% in a quiet environment, but in a noisy environment, obviously it's harder to hear, so they don't score quite so well. And these are the outcomes for our department from 1996 to 2014. So these are BKB scores. We actually don't use BKB anymore. We use the Arthur Boothroyd words. But on this axis, you've got the year, and then this axis, you've got the BKB score. And you can see the vast majority of the patients that we've implanted have scored 70 or above with their devices. It's not entirely without complication. I'm not going to dwell too much on that, but most of the time it's very straightforward. We're doing more and more of this sort of surgery under local anaesthetic, and the patients find that very straightforward and without too much trouble. Can we just play that video again? So this is an example of an adult describing his experience of a cochlear implant. If we can turn that up a little bit.
Yeah, I would definitely recommend it. Like I say, I was sceptical myself at first because I thought Mickey Mouse all the time. I go, was it? Like, what? It's amazing that it's so much like normal speech. And I wish I'd have gone in for it earlier, really, when I think about it.
So he referred to Mickey Mouse, and that's how some patients describe their initial experience of the cochlear implant. So it takes a bit of time for the brain to get used to the signal that it's getting from the electrical stimulation rather than the sound stimulation. But within 2 or 3 months, it's sounding much more natural, and people are able to use it and gain significant benefit from it. And if we can just play this video as well. This is a young child. Sorry. What's remarkable about this is how normal it is. So she's got a bilateral cochlear implant. So, she could hear what Lisa, our pediatric coordinator, was saying without looking at her lips. You could hear that she had normal speech, and she would have previously been profoundly deaf and had deaf speech as well. So I wanted to just move on to another really important topic, which I've touched on a little bit already, and that's unmet need. There was a paper published a few years ago now looking at the unmet need of patients that have profound hearing loss in the community. And this study suggested that around 75% of patients that have profound hearing loss don't actually get a referral to a cochlear implant centre. And that's why I think this document is really important. And if I can get you to take one message away from today, is to focus on what to do with patients that have profound hearing loss and get them referred, because we can make a huge difference to their quality of life. And then the other thing I think is really important, and I'm pretty sure I'm preaching to the converted here, but is education about what the criteria for cochlear implantation for when it's kind of those borderline cases. So this was a study back in 2016 that asked a whole range of community audiologists what they thought of 4 different audiograms. So I better just read it because I can't see from there. So the first audiogram was a single-sided deafness case. The second audiogram was an asymmetry in the hearing, but one ear was 75 dB, the other one was 90 dB on average. And then the third one was a ski slope hearing loss, very similar to the audiogram that I showed earlier on. And then the fourth one was an asymmetrical hearing loss, one with 95 dB pure tone average and one with 110 dB pure tone average. And you can see the percentage of individuals correctly answering whether or not these were within criteria for cochlear implantation on the graph. So this was prior to training, and this was after training. And you can see that, fairly shockingly, there was only 20% of people that said that audiogram 3 was in criteria for cochlear implantation. So it's 3 and 4 that are in criteria, and 2 and 1 and 2 that aren't. And you can see the profound benefit from training and making people understand the criteria. So again, I would encourage you just to look at that criteria and look specifically at each different frequency between 0.5 and 4 kilohertz, and if any of them meet 80 dB or in 2 adjacent frequencies, then consider that referral. So I'm just going to touch on a subject that's close to my heart. I'm not going to spend too much time on it because it's pretty esoteric, but it's a really interesting device that we implant for patients that are profoundly deaf where they can't get benefit from cochlear implantation. That's the auditory brainstem implant. So you can see here, fundamentally, it's the same design as a cochlear implant, but rather than having the electrodes arranged in an array along a long, thin electrode that's placed in the cochlea, they're arranged in a paddle. And that paddle is placed on the brainstem, just adjacent to the cochlear nucleus, and the auditory pathways are stimulated at the level of the cochlear nucleus rather than the cochlea itself. So you're probably not that familiar with neurosurgical anatomy, but basically the cochlear nucleus is situated in the brainstem, and there happens to just be a hole in the brainstem at that point that allows us to slide the paddle in so it sits adjacent to the cochlear nucleus. And this is just a video showing where it goes. So this is the back part of the brain with the cerebellum removed, or part of the cerebellum removed, and the electrode just slides in through that hole and is placed over the cochlear nucleus. And these are the sorts of things that we use this device for. So if you've got a vestibular cochlear nerve that's been removed from surgery or it's congenitally absent, then we can use a brainstem implant. Or if their cochlea has been destroyed, let's say, for example, they've had meningitis and the cochlea has become obliterated and we can't get an electrode in the cochlea, then we would use an auditory brainstem implant. And these are the sorts of outcomes, and I wish I could say that the outcomes we get from auditory brainstem implants are as good as cochlear implants, but sadly they're not. And you can see here that there's only a very, very limited number of patients that develop open speech discrimination. So there's a 10% in our population when we reviewed our first 50 cases. And you can see along the bottom a table with all of the results with the ABI alone, so without lip reading, the lip reading alone, and then the ABI and lip reading, and this is just reflected in the graph here. If you just use the ABI and you don't have any lip reading, then you score on average 11% with your speech discrimination testing. With lip reading, this cohort was scoring 18%, so they were doing better with their lip reading than they were with the ABI alone, which on the face of it seems pretty disappointing. But if you have the ABI and lip reading together, then you can score an average of 48%. So the ABI acts as a sort of adjunct to lip reading. It helps people get that timing of sounds. In a few patients, it does allow them to get some degree of open set speech discrimination, but it's certainly not anywhere close to as good as you'd expect for a cochlear implant. So that's pretty much all I'm going to say. Just to highlight the importance of that collaboration between community audiologists and clinicians in hospitals. It's really important to recognize those situations that I've mentioned and get those patients referred up either urgently or routinely, depending on the circumstances. And I hope that I've been able to demonstrate that actually there's pretty much a hearing rehabilitation option for everybody, except for maybe that 65 to 80 dB gap that we've got at the bottom of that pure tone audiogram that I showed you. Thank you very much.